Hello and a very warm welcome to this wonderful and very important chapter, beta. This is a 5 by 5 star MCQ topic about the healthcare system that we have in India. I have actually combined two bigger topics. We are going to talk about the primary healthcare. What do we mean by the primary healthcare? What are the elements and so on? And we will talk about the basic healthcare system that we have in India. In India is a big country. We always are talking about 140 crore population. Do you know that we are talking about the healthcare system being provided to 20% of the global population. Out of that 20% of the global population, can you imagine that 30% are age less than 15 years, 26, 27%, and 8% are age more than 60 years. So you have some young people, you have old people. How are you going to plan for the healthcare system? That is what we are going to study in this topic, in this video module. The competencies which are related to this video module, we need to talk about the basic concepts of healthcare to the community, primary healthcare, its components and its principles, national policies relating to the national health planning, and the healthcare delivery system in India. Of course, this is one high yield point for your PG entrance exam about the healthcare delivery systems that we have in India. So first MCQ, what is the structure of a healthcare system? What do you think? We are talking of providing healthcare facilities to all the Indian population. The structure should be that you are going to provide a primary healthcare, secondary healthcare, and a tertiary level healthcare. Primary level, secondary level healthcare, and a tertiary level healthcare. What do you mean by a primary level? This is the basic and the essential healthcare which is given to all the citizens of the country. The secondary healthcare system will talk about some specialized treatments which are there for secondary healthcare system, where you have some specialists which are available, and tertiary would be high-end hospitals or healthcare facilities which are going to provide some prosthetic maybe arrangements or rehabilitative surgeries, or this could be disability limitation, or it could be any high-end surgeries like transplant surgeries. That is all to be done at the tertiary level. So we want that a basic primary healthcare system should be there, which is available to everybody in the country. Next is point number 2. What is the approach to healthcare? So approach means that how are you going to provide the healthcare in the structure which is available, that is the primary, secondary, and the tertiary level. In approach, we want to provide a basic important healthcare to all the citizens of the country. First thing is we want to do health promotion. Please note, it is different from disease prevention. If you are healthy, I want to promote your health to a bigger health, a positive health, some more spiritual health, some more level of health. Second, I also want that all the citizens of our nation, they should be having disease prevention. So there should be some preventive healthcare services. Preventive services like immunization, like disease prevention, insecticide sprays, leprosy awareness, blindness control. Disease prevention has to be there. Third level, in case people have disease, the healthcare system should be providing them curative services. What do you mean by the curative services? Curative services, that means that in case of malaria, you should give them ACT. In case of leprosy, you give them MDT. In case of any tuberculosis, you give them ATT. In case of HIV, you give them ART. So you give whatever treatment we have in the system. Fourth is that we have started with the health promotion, preventive services, curative services, and in case a person gets unfortunately poliomyelitis, there should be a rehabilitative services. In case a person has disability due to visual impairment or blindness, you should give spectacles. So there should be disability limitation and rehabilitative services. So the curative and the rehabilitative would be provided at a more specialized center, but the health promotion and preventive services should be there available at the every grassroots level. That is what is the approach to healthcare in our country, India. Topic number 3, point number 3. What are the elements of primary healthcare? We want that what all things you are going to give. One is the structure, then is the approach, and now is the what are you going to do. What are the elements? The elements is that we want to have health education. We want to have locally endemic diseases should be prevented. The disease should be prevented, locally endemic. And then there should be essential drugs, mother and child health care. This is in fact the most important. EPI, that is the expanded program for immunization. Of course, now it is called as the UIP, and now it is called as the Mission Indradhanush, and now it is called as the intensified Mission Indradhanush. So many changes, right? So you have now the IMIA, intensified Mission Indradhanush. Then we also need in our country the nutrition supply. We need the treatment of common diseases and safe water and sanitation. And surprisingly, you don't need to memorize everything. The first alphabet of every word over here matches the word elements. So that's how you can just remember it. It's just a small thing for you. Elements of primary healthcare are actually the elements, ELEMENTS. Next is topic number 4. What are the principles of healthcare? This is like 3 by 5 star MCQ topic. A lot of times they ask you, what do you mean by the principles of healthcare? So we have talked about the structure of healthcare. We talked about the approach to healthcare. We talked about the elements of healthcare. Next is, what are the principles of healthcare? The principles of healthcare are the 4 pillars of our nation. We are talking always in terms of equitable distribution of the healthcare. We want community participation, intersectoral coordination, and appropriate technology. One point about all them. First topic that you learned was equitable distribution. You want an equitable distribution of healthcare. What do you mean by that? Equitable distribution. So what do you mean by equitable distribution? Equitable means equal distribution. Am I right? Answer is no. This is not equal. It's not talking about the equal distribution that everybody gets the healthcare. Nah. It is the healthcare will be given to that person who needs it more. So elderly, they need more treatment, more facilities. Pregnant female, they will need more facility compared to a non-pregnant female. A child will receive more health facilities compared to adolescent boy or girl. So equitable should be, that means as per health need requirement. That is what is a requirement. That is what is equitable care. Second is the approach that was there was about community participation. Community participation. For my side, I feel participation. From my side, I feel that this is one of the most important and the essential pillar of our healthcare. I'm not saying that this pillar is bigger or smaller. Every pillar is a pillar. Otherwise, the nation won't stand. So every pillar is a pillar, but the community participation has to be the most strongest pillar. Why? Because it involves a lot of community to be accountable for their health. In the chapter of concept of health, I told you that the health is supposed to be taken care by the individual. It's also supposed to be taken care by the family. It's also supposed to be taken care by the community. The cultural factors, the community factors play a very big role. And perfect example for this for you, in case you are UG student, this will be asked. In case you are PG student, you are PG aspirant, again this will be asked. Community participation, can you give me an example? Answer is a big example. We have Rogi Kalyan Smitis. We are going to talk later on. Rogi Kalyan Samiti. We also have ASHA workers. You've heard about ASHA workers. What is that? ASHA is the community participation. ASHA stands for Accredited Social Health Activist. So you're talking about the ASHA workers, you're talking about the Rogi Kalyan Smitis, you're talking about Mahila Arogya Smitis. So all these are actually examples of the community participation where we want everybody to come over and take over the health of the whole community. Third point that we have in the principles of healthcare is intersectoral coordination. That means we want different departments to work together for the healthcare system. In intersectoral coordination, perfect examples are there that the Poshan Abhiyan, the Poshan Mission, the Poshan Shakti Mission, Nirman Mission is with Ministry of Education and Ministry of Health and Family Welfare. You know about the Anemia Mukt Bharat program. Anemia Mukt Bharat program. It has 6 elements, 6 different departments working together. You also know about the ICDS program. ICDS takes into account, you remember in the chapter on ICDS, we discussed about the ICDS, Integrated Child Development Services, to be taken care by the Ministry of Women and Child Development and the Ministry of Health and Family Welfare. So we have so many ministries coming together towards the intersectoral coordination. And last in line you have is the appropriate technology, use of appropriate technology. We use nowadays, we have started using appropriate technology. What is Nikshay? What is 99 dots? What is Nikusht app? So we have a Nikusht app for leprosy. We have a Nikshay app for tuberculosis. We also have appropriate use of technologies, use of ORS with zinc. So adding zinc to ORS was basically a research-based model and we have started using it. We also have for better sanitation, you have the RCA type of latrines. The latrine, RCA type of latrine is used because it has shown that it is better in terms of the technological advancements we have. So these are the principles of primary healthcare, or these are the principles of healthcare in India. Next is, let us come to the section number 2. Section number 2, that is the next part, healthcare system in India. So first we discussed about the basics in primary healthcare or the healthcare system. Now, what is the healthcare system? How are we providing healthcare facilities to 20% of the global population? So let us first discuss about India, the civic system, and then I'll come back to the healthcare system. First, let's have a few words about India. Everybody should be at the same level. That's the reason I always take the civics class first. So in India, beta, we already know there are 28 states and 8 union territories. Of course, with quotes that this may change by the time you guys will be watching this video. But of course, 28 states and 8 union territories. In this 28 states, we already know there are 750 districts in India. We have 750 districts. Each district is further divided into basic populations. So the population would be subdivisions. There is no category like for 10 lakh people, this much is subdivision. These are just administrative components. So subdivision, then below subdivision is what we call as tehsil. Tehsil or the taluk in some areas, they call it as mandals or taluk or the tehsil. So again, there is no defined population for every tehsil. It could be bigger, it could be smaller. And below tehsil, you have the blocks. Below tehsil, we have the blocks. The blocks are for defined population, roughly around 100,000 population, that is 1 lakh population. That is 1 lakh population will be defined area for the blocks. Now moving below, the blocks could be further categorized into urban areas, or they could be categorized into the rural areas, right? So you can have blocks in the urban or in the rural. So in the urban areas, you are going to have different differentiation. In the urban areas, the block may further be categorized into towns or municipal boards or the municipal corporations. We may have the town, the municipal board or the corporation. The municipal board or the corporation, they usually occur in cities. I think you all must be there in village area, in the rural area, or you might be there in urban area. There's no third area, right? So either you are there in the urban, you may live in a town or a city. So when do you classify a town as a town? We classify a town as a town if it is more than 5,000 till 10,000 population. So the block may further have 10 towns into it, or 10 towns will make one block, or it is a municipal board. We say municipal board if the population is 10,000 till 200,000, that is 2 lakh population. Or in case the population is more than 2 lakh, it is a municipal corporation. In case it is more than 1 crore, that is a metropolitan city. But all said and done, please note that the cities what is the size? That's the MCQ. The size of the city would be roughly anything between 10 to 2 lakh population. It could be even more. So in case the population of a city is more, you form a municipal corporation. In case it is a small city, municipal board. In case it's a small town, that is 5 to 10,000 population. Now coming to the rural areas. In the rural areas, we have very commonly asked, like I think everybody knows, we have is the Panchayati Raj system. Now talking into the Panchayati Raj system, now going into the Panchayati Raj system, at the lowest level, we have a village. At the village level, we have a Panchayat. We have a Panchayat at the lowest village level. In this Panchayat at the lowest level, we may have a Gram Sabha. Then we actually have a panchayat. This is also called as a Gram Panchayat. The Gram Panchayat will usually be for 15 to 20 villages or even up till 30 villages. There is no defined population, but usually for 15 to 30 villages, you will have one Gram Panchayat. One village, I would like to tell you over here, one village is for, usually we say it is for 1,000 population. Please note, I have 2 times told population, defined populations over here. One time was when we talked about the town and the cities. Second time was, of course, in the block also. So 3 times. So one was in the blocks. Second was when we talked in the towns and the cities. And third time I'm going to talk about the village. So these are defined populations. Then above the panchayat, we have something called as the Panchayat Samiti. Panchayat Smiti. The Panchayat Smiti, just one MCQ beta, is for how many villages? It is for 100 villages. Can you think and tell me, if it is for 100 villages, that means it is for how much population? One village, 1,000. So it is for 1 lakh. Can you think and tell me 1 lakh is for which level? The block, the tehsil, the subdivision, district, state, or the country India? What do you want to say? Answer is block level. So can I say that the Panchayat Smiti works at block level? It works at block level. Next in line, above the Panchayat Smiti, we have something called as Zilla Parishad. We have the Zilla Parishads. The Zilla Parishad is working at what level, beta? It is working at the district level. Are we okay with this? This is the simple civics that I wanted to discuss with you. I cannot teach you the healthcare system until and unless you know what is a village, what is a block. When do you say Zilla? When do you say Tehsil? When do you say block? When do you say Mandal? When do you say districts? And when do you say subdivisions? And when do you say country India, right? So the India country is divided into states and union territories. Each will have the districts. The districts are going to have the district committees, or they will have the Zilla Parishad, right? At the district level is Zilla Parishad. So this is Zilla Parishads. And then there is the subdivisions, and below subdivisions you have the taluks, and then you have the blocks. At the block you have the Panchayat Smitis. And then if it is a village, it is a Gram Panchayat or a Maha Panchayat. And in case it's a town, it could be in case it's an urban area, it could be a town committee or a municipal board or a municipal committee. This is what country India is. Next in line, now if you have understood this, let me take over to the healthcare system that we have in our country. But what I would like you to do is, in your copies, I'll write down differently, you write down differently. What you do in your copies is, you make in your copy area like this, and this big area you leave it. So I want you to make your copies in 3 sections. You take, in this area, I'm going to write down something. In this area, we'll write down, and then this section. So right now, let me focus over here. In this area, let us talk about the rural healthcare system. Then in this area, we will talk about the urban healthcare system. And in the first area, I'll talk later on about the WCD ministry, education ministry, other sectoral healthcare systems. So let us first focus on, a lot of MCQs come from this area, the rural. So I'm going to write down the rural healthcare system. Beta, the vertebrae of the rural healthcare system, the center, that's the spine of our country. At the lowest level, we have the village. Am I correct? Above the village, we have something called as the sub-center. I'll write down in short forms. Sub-center, then we have the PHC, then we have the CHC, and then we have the district hospital. This is the healthcare system that we have in our country. What is all these abbreviations? District hospital means the district hospital. CHC, it means a community health center. PHC stands for a primary health center. And SC stands for sub center. And VLG stands for the village. That's just my own abbreviations. It's easy because I'll be writing these so many times now. So at the first level, you have a district hospital. Below that, the CHC, the PHC, the sub-center, and the village. First MCQ. What are the population norms of these? First MCQ. What is the population norm of these? Village. I think we have had a lot of discussion. It is for 1,000 population. Please note that the sub-center will be for 3,000 population in the hilly area, tribal area, forest area. It is for hilly area, tribal area, And the forest area, this I'll write it as HTF areas, hilly area, tribal area, forest areas. So in the jungle areas, hilly areas, 3,000 population will have one subcenter. Then at every 5,000 population in the plain areas, you are going to have the subcenter. As far as the PHC is concerned, it is for 20,000 population in the hilly areas, tribal area, forest area, 30,000 population in the plain areas. The CHC is for 80,000 population in the hilly areas, tribal areas, forest areas, and for 1,20,000 population in the plain areas. District population, there is no population. District hospital will be available at a district level, Zilla Parishad level or the district level. Next, the question may ask you like who is sitting at what all level, who will be available at what level. At the village level, beta, we have some person called as the ASHA worker. We'll write down everything later on about the full forms, ASHA worker. At the sub-center, you have two people. One is called as a MPW. Second is also called as a MPW. One is a male, another is a female. So there are two MPWs, male and a female. At a PHC, who is available? At a PHC, we have a medical officer. We have a MO. MO stands for the medical officer. MO is the medical officer. So now at the PHC level, we have a medical officer. So the medical officer, how many medical officers do we have? We have 3 medical officers. So we have a MO in charge, which is a normal MBBS doctor. We can also have MO Ayush, which is from the Ayush ministry. And we can also have a MO dental at a PHC. So what does this Ayush stand for, beta? Ayush. Ayush stands for Ayurveda, Yoga, Unani, Siddha, Homeopathy. So at the PHC level, we may have 3 MO medical officers, plus alongside we will have the auxiliary nurse midwife ANMs, plus we have a very important person, that is the pharmacist. Plus we will have all the other workers, plus we have a person called as health assistant. This is the health assistant available at a primary health center, PHC. Next is who is available at a CHC. Beta, at a CHC, we will have specialist. Who are the specialists which are available? At a CHC, there will be 6 specialists. First is 4, medicine, surgery, gynae, peds. So there are the 4 specialists, plus very recently we have started with 2 new specialists, that is anesthesiologist plus ophthalmologist. So these are the specialists which are available. So let's write it down in our table. So you'll have 4 basic specialties, that is medicine, surgery, gynae and pediatrics, plus there will be anesthesia, plus there will be a ophthalmologist. Plus there will be the same old people, ANMs will be there, pharmacist will be there, plus there is lab technician also now. Plus there is also OT technician. OT technician will also be there because surgeon is there, anesthesia is there, they need OT technician now. So now there is OT technician and there is laboratory people also. There is laboratory technicians also, lab people also will be there at a CHC. It's kind of a full-fledged mini functioning hospital. So there we can do surgeries and a lot of things can be done. At a district hospital, beta, who is available? We take all the clinical specialty. Don't answer physiology or biochemistry will be there. So there will be all the clinical specialties plus one biochemistry will also be there. Very soon we'll look into it. Clinical specialities plus there will be specialized laboratories. Now you will have specialized laboratories. That means there will be a biochemistry lab, there will be a microbiology lab, there will be a pathology lab. So specialized laboratories plus there will be staff nurses, and there will be ANMs, pharmacists. It's a big hospital, right? Everybody's worked in a district hospital. Plus, there is also a person called as program manager, PM. PM stands for the program manager. We have PM, that is a program manager. So this is what we have, beta, in the rural healthcare system. So this is what we have, beta, in the rural healthcare system in our country, that we have a district hospital, below that the CHC, PHC, subcenter and the village. So now this is the manpower and the population norm. Let us go and talk about each one of them now. If you talk about the first one, that is the ASHA worker. Let us see who the ASHA worker is. ASHA worker stands for accredited social health activist. It is an accredited social health activist. MCQs on ASHA worker. ASHA worker is usually the female. What is the age group? It is 25 to 45 years. Female should be there. Next is this ASHA worker. What should be the education level? We were taking as the criteria as 8th pass, but now recently we have shifted to the 10th pass as the educational criteria. This female should be daughter in the village or daughter-in-law. She should be married in the village or unmarried girl. Of course, she has to be married because we want an ASHA worker to be a permanent resident of the village. She should be married in the village and a permanent resident. So it not necessarily means current marriage. She could be divorced, she could be widow, she could be anything, or she could be married, but she has to be already married and a permanent resident of the village. It could even include the divorce or the widow or the married, whatever. What do you want? The ASHA worker should be having a child, yes or no? Definitely yes. We want the ASHA workers to have at least one child. At least one child. Why? Because if the ASHA worker already had a child, only then she'll be able to understand how to take care of the diarrhea or the child needs or breastfeeding or immunization, so on and so forth. At least one child, but not more than 2 children. Not more than 2 children. Why not more than 2 children? Of course, why? Because she's going to do family planning. She's going to promote family planning. She can't have 5 children and say that you have 2 children, right? It's not done. So the ASHA will have 2 children, not more than 2 children, at least one child, and she should be preferably a mother, and she should be married, living in the village, 10th pass, 25 to 45 years of age. To this ASHA worker, how will you make her an ASHA worker? What is the difference between a normal female and an ASHA worker? This ASHA worker is really an ASHA worker if she undergoes the induction training. The induction training means the initial training we give to the ASHA worker. The induction training is for 7 days initially. Then there are 4 groups, 4 sessions of 4 days each. So 4 days into 4 sessions. That is how many days? 16 days. So how much it comes out to be? 23 days. So please note that the ASHA worker is going to complete the 23 days of induction training to actually become an ASHA worker. So ASHA worker is trained. She's trained for 23 days. Please note she's trained for 23 days. Next is, what are the functions of ASHA worker? Functions of ASHA worker. Please note that the functions of ASHA worker are pretty important in case you are a UG student. The first function is to do home visits. So she has to do 3 to 4 days of home visits. Second is to visit the health facility. She also has to visit the health facility. Third very important function is that the ASHA worker will be responsible. She is an important member of something called as the VHSN committee. What is VHSN committee, beta? It is the Village Health, Sanitation and Nutrition Committee. It is the Village Health, Sanitation and Nutrition. Village Health, Sanitation and Nutrition Committee. That is the VHSN committee. She is an important member. She is an important member of the VHSN committee, and actually the VHSN committee is the committee which is going to implement all the national programs at the village level. So these are the 5 important functions, bache. The ASHA worker will need to visit the health facility. The ASHA worker will attend the village health sanitation days and the village health sanitation committee members whenever they meet. The meeting should be there. The home visit should be there. She's going to maintain the record and hold the MAS meetings. What is MAS? That is the Mahila Arogya Samiti. We'll talk about MAS later on. It is the Mahila Arogya Smiti. So she is going to hold the meetings for the Mahila Arogya Samiti. These are some females who are going to do community participation. So these are your few functions about the ASHA worker. Next is, let us talk about the MPW male or MPW female. What does MPW stands for? It stands for the multi-purpose worker. MPW stands for the MPW. It stands for the multi-purpose worker. Beta, the MPW could be a male or the MPW could be a female. Anything which happens, so now I'm telling you the functions of them. So anything which happens in the village for anything, for the vector-borne disease, malaria slides, insecticide spray, Japanese encephalitis finding, dengue sprays, insecticide sprays, malaria slides, chloroquine tablets, ACT to be given, fever treatment depots, anything which happens in the village for vector-borne disease. Anything which happens in the village for the vector-borne disease like the malaria slides, like the insecticide spray, like the fever treatment, anything which happens for the vector-borne disease, this is the work of MPW male. Please note that long time back, 1973, Kartar Singh Committee, they formulated the MPW. We'll write it down later on, but I'm just trying to make a point over here that how did they form the MPW? It was the same cell lineage. That is, earlier the malaria workers were there. They made into different posts, basic health worker, and finally they became the multi-purpose worker. So this is the same cell system that is going to happen. So one of the main important work that they are doing is the vector-borne disease. Second, the male is also responsible for anything which happens in the village for diarrhea. That means for water quality. They will be responsible for the water quality of water in the village. In simple words, they are going to be responsible for the chlorination of the wells and chlorination. Safe water supply is primarily the responsibility of a male worker, MPW male. Next, third important thing, they are also responsible for record keeping. And register maintenance. That is being done by the MPW male. Next in line, the male will also be working for the OPD. They will also do the survey in the area, and general maintenance of the sub-center is going to be done by the MPW male. Now, malaria is done by MPW male. Chlorination is done by MPW male. OPD will be done by MPW male. Survey is done by MPW male. Record keeping by. So what is the female going to do? The female is going to do very important function. The female will be responsible for anything which happens in the country for the mother and child health system. Anything which happens in the country for the mother and child health system, that means conducting the antenatal care, doing the postnatal care, doing the immunization, helping in immunization, everything is done by the MPW female. Family planning methods, growth and development, so many things. Visit the chapter on MCH. Whatever is being done, MPW female. So MPW female is primarily responsible for the MCH indicators in our country. Next, this MPW female will also work for the eligible couples and maintain their register for family planning, eligible couple register, everything is being dealt by the MPW female. This female will also be responsible for doing the OPD, for conducting the survey. They both will go together, MPW male and MPW female. So now let us see about the administrative component. I already talked to you regarding the ASHA workers. When was the ASHA worker developed? Like when was she formed? The post of the ASHA worker, they were developed under the NRHM in year 2005. What about the MPW? The MPW posts were developed by the Kartar Singh Committee in 1973. So actually the MPWs, ASHA worker will go 23 days of induction training. We already told MPW will undergo a 1 year of training. That's a 1 year of training to become a multi-purpose worker. So 1 year training period, 1 year course is there for the MPW worker to become a MPW worker and to be able to provide health system in the healthcare structure of our country. Now comes to the next level. What is available at a PHC? Medical officer will be available. So at a PHC, MO will be there. So there are no functions. Like we all know what are the functions of a medical officer. They will be the team leader. They will do medical OPD. They will do surgeries, small surgeries, or they will take care of the medical system, drug system. Everything is done by the medical officer. The ANMs will be there, pharmacist will be there. What is this health assistant for? What is the use of health assistant? See, try to understand that if you are working in a PHC, or let us say any doctor is working, you guys will be big people, right? You'll be working in big multi-specialty hospitals as a specialist or super specialist in very soon time to come. So let us say that a doctor was working as a PHC doctor, and let us say that this PHC doctor, how many MPWs will be under that? Can you see that the PHC is available at a 30,000? So in 30,000, how many sub-centers will be there? Approximately 5-6 sub-centers. And below the sub-centers, you have the villages, that is the ASHA workers. How many ASHA workers will be there under one PHC? So you'll have one ASHA for 1,000, one ASHA for 1,000. So 30,000 will be 30 ASHAs. So we are talking of 5-6 sub-centers. That means 10-12 MPWs and 30 ASHA worker, 40-45 people. Please know that in the whole country, every month, the PHC is going to conduct a monthly meeting. In that, so many 40-45 people will be coming. So all have to be managed. This management of the lower health staff, of the grassroots workers, is done by the health assistant. So he's just an assistant to the medical officer. They will be taking care. The health assistant is going to take care of the health assistant is going to take care about the supervision of the health staff, and is going to assist in the administrative functions, of the PHC. That is the work of health assistant. Next in line, you will ask me that what is the work of the PM? What is PM? PM stands for the program manager. Now, what is the use of program manager? Please note that the program manager is responsible for management of programs, of the national programs at district level. Where is the program manager available? At the district level. So please note that the program manager is available at the district level. So all the health programs, they are functioning at the district level administration. So all the health programs are available at the district level administration. And now last point for us to do is that in this whole vertebrae of the rural healthcare system, how many beds are available? So I've talked to you three things about the population norms, about the manpower norms, and about the bed systems. So at a village level, ASHA, how many beds will she have? Answer is common sense. There is no beds for the ASHA system. At a sub-center, MPW will be there. The immunizations may happen. So there could be 0 beds, that is no beds, or maximum we can have up to 3 beds. Of course, if a sub-center is bigger, there may be more, but very soon I'm going to talk a little bit more in detail about the sub-center. But for now, I'm just drawing the beds over here. You can write down that 0 to 3 beds are there in a sub-center. In a PHC, 4 to 6 beds usually. In a CHC, it is usually more than 30 bedded hospital will be a CHC. And a district hospital could be big, 100 bed, 200, 500. But anything more than 80 is usually a district hospital. So how many number of beds are there, beta? 80 beds, and more than 80 beds in district hospital, more than 30 in CHC, 4 to 6 in PHC, sub-center is 0 to 3, ASHA, no bed. So this is what you have learned, beta, in the rural setup, that we are going to talk about the CHC, the PHC, the sub-center, and the village. Now let me play the game over here for the urban sector. So what are we going to write down in the urban sector? So let us say in the urban areas, you already know that in the rural areas, what was there? In the rural area, there was a district hospital. Of course, district hospital is a combined, it's not only the district in rural or in urban. So below the district, you had the CHC, then you had the PHC, then you had the sub-center, and then you had the village level ASHA worker. In a rural setup, it is the same setup. You don't need to bang your head. The manpower is same. Everything is, the beds is same. The population will be slightly different and the names that we say is different. And in the urban area, in the rural area, in the village, you were having ASHA workers. In the urban areas, we have somebody called as the urban ASHAs. Urban ASHAs also called as the USHAs. So who is USHA? USHA is urban ASHA. Then above the urban asha at the sub-center level in the village, now above the urban asha you have something called as the A&M center, and then you have the urban PHC called as the UPHC, then you have the urban CHC called the UCHC, and above UCHC you have the district hospital. So what is UCHC, UPHC? UCHC stands for the urban community health center, then you have the UPHC, then you have the A&M center. What is A&M center stand for? A&M stands for the auxiliary nurse midwife. Auxiliary nurse midwife is what is the A&M. So that's what is the norm in the urban sector, that you are going to have the USHAs, then you have the A&M center, UPHC, UCHC. MCQs on this now. How much population for each of them? The urban ASHAs or the USHAs, they will be responsible for 1,000 to 2,500 population. Okay. So now in the urban sectors, you don't have villages. We have small towns or we have communities. So the urban ashas, we cannot usually talk in terms of the population. What is the population she is catering to? She is catering to 1,000 to 25. How many households are there in the community? That is what the MCQ wala will ask you. Taking a reasonable number of family size of usually 5, how many houses she will take care? So the houses would be roughly ranging from 200 to 500 houses. Hai na? If you take a family size of 5, 200 to 500 houses for urban ashas, then the A&M center is for 10,000 population, UPHC is for 50,000 population, urban CHC is for 250,000 population in all the cities. 250,000 population, and in case of metropolitan cities, it is for 5 lakh population. For metropolitan cities, for 5 lakh population, urban CHC 250,000 for all the cities, UPHC 50,000, A&M center 10,000, USHAs or the urban ashas, that is for 200 to 500 houses or 1,000 to 2,500 population. That's all that you need to remember for the urban system. So let's write down in the urban sector. In the district hospital, you have a UCHC, then we have a UPHC, then we have a urban A&M center, and then below the A&M center, we have the urban ashas or the USHA workers, right? So this is what you have learned in the rural sector and the urban sector. Now, let me just tell you that the rural sector that you had learned, whatever there was, PHC, CHC, subcenter, this whole thing, beta, is called as the National Rural Health Mission. So what you have learned is the structure of the National Rural Health Mission. Whatever you did in the urban sector, that is actually the National Urban Health Mission. So under the National Urban Health Mission, we started with the urban sector. The whole thing together combined in India is what we call as the National Health Mission. So right now what you're seeing is the components of the National Health Mission, that there is a rural component, there is a urban component, and within the urban and the rural component, this is what you have within the National Health Mission. So now, after learning about the NHM, National Health Mission, let us talk to you about the last extreme, that is what is the other system that we have in the healthcare system. In the other system, we are going to talk about the ICDS scheme, beta. What is the ICDS scheme? It is the Integrated Child Development Services. Please note, Child Development Services. It's not a scheme, it's a services. It was initially launched in year 1975 under the Ministry of Women and Child Development, MOWCD, Ministry of Women and Child Development. It was launched under the Ministry of Women and Child Development. Under this ICDS scheme, beta, we already have a special session about the ICDS scheme. Over there also I had discussed. Right now, just to give you again an overview about the organization of the ICDS, Integrated Child Development Services scheme, is that at the lowest level, beta, we have Anganwadi. At the lowest level, we have Anganwadi. One Anganwadi is for usually 300 to 800 population. If you get single best answer, we usually take 800, but grossly for calculations, you can take 1000, but that is just with the quotes. If you get single best answer, 300 to 800 population, we take one Anganwadi worker. This Anganwadi worker is for 300, 800 population, and then above the Anganwadi worker, you must have read it in ICDS program that there is a person called as the Anganwadi supervisor. This Anganwadi supervisor is going to have 25 Anganwadis under her. So this supervisor is for roughly approximately 25,000 population. 25,000 population is the population norm for the Anganwadi supervisor. Next, above the Anganwadi supervisor, we have a person called as a big boy, that is the CDPO. What is a CDPO? It stands for a child development. What do you want to say for P? P stands for child development project. Don't answer panchayat. It's a child development project officer. It's not a BDPO, block development panchayat officer. It's a child development project officer. Now this is an officer level, right? So the CDPO is responsible for 4 Anganwadi supervisors. So totals, what is the population for CDPO? Can I say that the CDPO is for 100,000 population? Are we getting it? So now this is just the structure of the ICDS program. That's all. And above this is the Ministry of Health and Ministry of Women and Child Development. So now if I just plot this ICDS program over here in the summary table that we are building, where should I write the Anganwadi worker? At the lowest level. So let me just write down the Anganwadi worker at the lowest level. What is the population norm for this beta? Anganwadi worker. We talked about the Anganwadi worker. She is for 300 to 800 population. Okay. Then is the Anganwadi supervisor. At what level should I write the Anganwadi supervisor? She is not at this ANM center. Why? Because ANM center is for 10,000, sub center is for 3 to 5,000. The Anganwadi supervisor is for 25,000 population. What is the population for UPHC? That is 50,000. What is the population for PHC? That is 20 to 30,000. That's what we had done. Next is this Anganwadi supervisor is under a CDPO. CDPO is working at what level? CDPO is 1 lakh population. CHC, urban CHC is for 2.5 lakh population, but rural CHC is for 1 lakh population. That is at the block level. CDPO is also for 1 lakh population. So which is the block level hospitals that we have in India? The block level hospitals that we have in India is the yellow color zone. These yellow color zones, these are the block level hospitals that we have in our country. Next in line is which is the lowest most system that we have. The lowest system that we have is the Anganwadi worker, the USHA, the ASHA, the MPW, the ANM centers. These are our workforce. We are very proud of these people. They are the pillars of our country and they are the reason for which we could handle the COVID pandemics. And that is the system of immunization. That is the system of family planning. So many things are being done by the grassroots workers. Next in line is that which is the administrative unit. Please note that the administrative unit is always the district level. District level is the administrative unit in the health system. Which is the administrative unit in WCD ministry? In WCD ministry, the administrative unit is the CDPO. I'm sorry for drawing so many things in a single slide, but I wanted to show you that how the country is functioning. At the lowest level, you have these grassroots level worker, then you have the supervisor level, and then you have the functioning people, that is the block level, and then you have the administrative component, that is the district level. Did you get this point? It's pretty important to understand. This is how many of you must be working somewhere in these areas, but many of you must not have seen the system. So I want you to visualize that how the country is working, that what is happening at what level. So who is the equivalent counterpart? I hope you understand that this is the Anganwadi system on the extreme left. It is under the WCD ministry. I hope you understand the word that I had said in some other videos. I have said it a lot of times that I say it, I don't say it. The administrative unit in a health system is the district level. Administrative unit in health is district level. The administrative unit in any program which is not health is never district level. For example, is the ICDS program. The ICDS program, who's the administrative unit? Who's the in charge? It is the CDPO. In charge working at what level? It is at the block level. So what is the administrative unit of a WCD ministry? WCD ministry, or the Ministry of Women and Child Development, is working at what level? Block level. You know ESI program. ESI is by which ministry? Labor Ministry. ESI, I hope you know, na? ESI, Employee State Insurance Scheme. So the Employee State Insurance Scheme is by Ministry of Labor, and it is working at what level? The name says the state level. Anything which is health will be district. Anything which is not health will never be district. That is what you need to take home summary is for the day. So this is just a neat diagram of the same summary table that I have made for you. You need to know that who is the grassroots level working systems that we have. This is the grassroots level, which is the supervisory system that is at the PHC level. Who is the supervisor in PHC? You remember in a PHC we had a health assistant. The health assistant is equivalent to the supervisor. Then we have the CDPO. CDPO is actually equivalent to the in charge of a community health center, or the chief of the community health center. And then we have the district hospital, which is working as the main administrative unit. Now I think you should be able to understand what do we mean by the Rogi Kalyan Samiti and the Mahila Arogya Samitis. So these are beta examples of community participation. Community participation. What happens is that you already know about this triangle, right? We have the CHC, the PHC, the sub-center, and the ASHA workers, Anganwadi workers at the lowest level. What happens is that the CHC is there, a hospital is there made by the government of India. Now the hospital, let us say you are working as the in charge of the CHC, you want to do something more, you want to open more laboratories, you want to do something else, where will you get the funds from? Or in case you have the funds, who is going to manage all this system? So what we do is we call something called as the RKS system or the Rogi Kalyan Samiti. It is just a collection of some senior people. Senior means educated people. So senior people from community, they will come together and manage the health facility which is available in their area. Are you getting it? So let us say that you are working at a PHC. You want to start some laboratory test for thyroid testing or some other testing. So where will you get the funds from? You'll ask the RKS system. So the RKS is, there is a PHC RKS for the PHC, then there is a RKS for the CHC. So the RKS is going to take care about the health infrastructure. Let us say the fan is not working, or you want a new AC in your room, and the public may be paying for it. So there will be a contribution from the government, there will be contribution from the community. So technically RKS is nothing but a community involvement. Are you getting it? RKS is nothing but a community involvement for management of the health facility. That is the only thing. What is this Mahila Arogya Samiti? It is a like Smiti. Smiti means collection of people. It's a female collection, only the females, and usually from the urban sector. Urban sector, it could be from the rural also, urban or rural. We can have anywhere, the Mahila Arogya Samiti. So this is the female groups which will help in health, growth and development of the children. They will help the Anganwadi worker. They will help for making food in the centers. They will help for the ASHA worker in performing her duties. They'll help the USHA workers. So Mahila Arogya Samitis are there, which are voluntary organizations by the community in helping the grassroots level workers. What is this RKS for? Beta, it is for the management of the health facility. So the RKS is primarily at the top level. At the lower community level, we will have the Mahila Arogya Samitis. That is, some females, they get together to help the health system in India. So the RKS is for health management. That is to have better management of the PHC or the CHCs, performing new tests at different health facilities. Another topic that can be asked to you in your exams is, what is this IPHS? IPHS, your next topic is Indian Public Health Standards. Beta, you all must be working in big corporate hospitals. The corporate hospitals are usually accredited using the National Accreditation Board system. That is the NABC. system. So the NAB system, National Accreditation Board, could be for two things, either for the hospitals, NABH, or we can have the NABL, that is the National Accreditation Board for the hospitals. You also might be working in big super specialty hospitals where there is JCI accreditation, Joint Commission International. It is a Joint Commission International, that is the JCI accreditation. That is the super biggest accreditation where people will have medical tourism and international patients may be coming. But in a government system, we have our own standards. These are our government cool standards, that is the IPHS standards. So what is IPHS standards for? These are the standards for quality maintenance. They are the standards for manpower in health facilities. They are the standards for financial rules in the health system. So they are basically for the quality, for the manpower, and for the financial, we have the IPHS standards. So as per the IPHS standards, now there could be two important things for us to understand. There could be a sub-center or there could be a PHC. In a sub-center, there is two types of sub-centers. Now I'm getting into it. So as per the IPHS standards, there are some norms. The sub-center could further be classified into sub-center A or sub-center B. The PHC could be classified into PHC A or PHC B. So sub-center A is a sub-center where there is no facility for delivery. There is no facility for the delivery of a female. Right? So there is no facility. So in case there is no facility, that is called as subcenter A. In B, I have remembered it B. B means birth. Birth means delivery. So in case there is a facility, for delivery services, then there is this called as a subcenter B. So common sense. Now you tell me in subcenter A, how many beds you will need? Either we put 0 bed or max you need 1 bed. Max you need 1 bed. In a subcenter B, you will minimum require 2 beds. There could be 3, there could be 4 or whatever number of beds. Are we getting it? So you need 0 to 1 bed in subcenter A, 2 to 3 beds or 4 beds depending on the load in the subcenter. The subcenters could be high load subcenter, low load subcenters and so on. The PHC could again be called as a PHC is a 24/7, right? PHC is usually a 24/7 functioning unit, and in the PHC you are supposed to conduct a delivery. Normal vaginal delivery has to happen at a PHC. So in a normal vaginal delivery in a PHC, the PHC could be the PHC A or PHC B. In a PHC there are less than 20 deliveries per month. Less than 20 deliveries per month, and in the PHC B, there is more than 20 deliveries per month. If it is more than 50 deliveries, it is called as a high load PHC. So more than 20 is called as PHC type B. In a type B PHC, there could be anything ranging from 6 to 8 beds, and in a low load PHC, there could be 4 to 6 beds. Are we getting it? So different types of bed facilities are available in different, as per the different IPHS standards. So this is what you need to remember for your exam, and just a small summary table that we have built for you is regarding the population and the covered area and the healthcare system. So what is the level of care? At a subcenter PHC, you are giving the primary care. At a CHC, there is the specialist care. Then at the population norms, we have discussed the staffing pattern. Usually in a subcenter, there will be 3 to 4 staff. In a PHC, it is usually, you can just remember one word for a PHC, it is usually 18 to 20 staff is there. That is the desirable ideal staff in a PHC. It could be as low as 13, it could be as high as 21, but we want a higher staff in a PHC. Similarly, in a CHC, single one word, if you remember, 50 people are there in a CHC. So that's just an easy way to remember how the health system is functioning. About the maintenance, you already have talked, like it's both center and state government. The type A subcenter is where there is no delivery facility. Type B is where there is delivery. Type A is less than 20 and type B is more than 20 deliveries in the subcenter. With this summary table and beta, with this summary table, I think we have covered more than 95% of the MCQs which will be asked from the healthcare system that we have in India. So now what we have already done is the basics in primary healthcare. We talked about the healthcare system. Let us come to the section number 3 about some of the other healthcare systems that we have in India. The first topic in the other healthcare system is the National Health Mission. In fact, it is not any other health system. It is the health system that we have in India. We already had a word about National Health Mission, beta. It composed of two elements. It has the National Rural Health Mission and it has a National Urban Health Mission. And now we talked about this. The National Rural Health Mission was launched on 12th of April 2005. And the National Urban Health Mission, it was launched on 1st of May 2013. Right? And the National Health Mission was started with the National Urban Health Mission only. So the government started the National Urban Health Mission and the National Health Mission all together because NRHM was very successful. So 2 MCQs on this, that's all. So what is there inside NHM? We have discussed so much in detail in the last 1 hour. Next in line is second MCQ. What are the components of National Health Mission, beta? So that is your question number 2. What are the components? There are 5 basic components. You need to memorize each one of them. The first and the biggest component is about the communitize. Communitize means to launch ASHA workers, to have the RKS committees, to have the Mahila Arogyas Mandals or the Smitis, then to have improved management through capacity, better management. Next is this flexible financing. Flexible financing was in fact one of the most needed points in the healthcare system, in the health sector in our country, that some programs we were having short of money and some programs were having surplus money. Next is innovations through human resource and monitoring of progress. These are the 5 important components in National Health Mission. Next is what is the approach in a National Health Mission? What is the approach of the National Health Mission? National Health Mission, in the center part, we had 4 approaches. That was to provide equality of care. Equality means that you provide equal amount of care from Jammu Kashmir till Kanyakumari. In the whole country, there should be equal care. There should be equitable care. Equal care, equitable care. There should be equitable care. That means as per requirement, the care should be there with the age, high age, low age, pregnant female, non-pregnant, lactating mother, under 5, under 15, whatever. So equitable care as per the requirement. It should be equal care among the different sectors. It should be equal for the below poverty line. It should be equal for the above poverty line. It should be equal for rich and poor. Effectivity and efficiency. Efficiency means that you should be able to have a good cures. Effectivity means, efficiency means simple. The input output should be efficient. Effectivity means that it should be able to reach the people and people should be able to use it. That is, there should be more affordability. There should be more acceptability. And because if there is more affordability and acceptability, there will be more utilization of the health resources. That is what is National Health Mission. So National Health Mission wanted to do 4 approaches: equal healthcare, equitable healthcare, efficient healthcare, effective healthcare. They all mean almost the same to a person who's not understood this. Right? Am I correct? So a National Health Mission is going to have equal healthcare, equitable healthcare, efficient healthcare, effective healthcare. So after this, the next one is Ayushman Bharat scheme. That is your point number 3. In fact, this program, Ayushman Bharat program, is not just another program. It is one of the center stage programs now. And we are very proud to say that Ayushman Bharat is the world's biggest, largest health insurance scheme. So we already have had a detailed discussion about Ayushman Bharat scheme in the separate module about the newer strategies and the newer policies in community medicine. So just to revise over here, very superficially, I'm going to tell you Ayushman Bharat, it has 2 sectors, it has 2 arms. One is the Pradhan Mantri or the Prime Minister Jan Arogya Yojana. It is the Prime Minister Jan Arogya Yojana. What is this Jan Arogya Yojana? It is nothing but to provide health insurance. It is nothing but to provide the health insurance to the general population. Next in line, the other arm of the Ayushman Bharat is what? That is to provide the comprehensive primary healthcare. It is to provide the comprehensive primary healthcare to the population. So MCQ, how to provide the comprehensive primary healthcare? That is by opening the health and wellness centers. This can come in your exam, beta. This is a prospective MCQ. Health and wellness centers is your MCQ, 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 5-star MCQ topic. So what is the component in the health and wellness center? In the health and wellness center, a new post is now launched under the Ayushman Bharat, that is called as the CHO. These are the community health officers. These are basically the nursing staff. This is a nurse. Community health officer is not a medical officer. It's a nursing officer who will be available at the health and wellness center. The government wants to have 1.5 lakh health and wellness center functioning. So this nursing officer or the community health officer is basically available at what level? What do you want to say that this person will be available at what level? Health and wellness centers are now integrated with the sub-center. So they will be functioning along with the sub-centers. In fact, many sub-centers have been upgraded to a health and wellness center. In the health and wellness center, a CHO will be there. The multi-purpose workers will be there. Male, female, they are going to provide health at the lowest level. And they will be also having a better healthcare system. Right? So that is what is the Ayushman Bharat scheme. It is one of the world's biggest health insurance scheme, and the government is trying to provide health, a better kind of health at the lowest grassroots level. And next, just before we close off this topic, is what are the suggested norms? Beta, this is a 7/7 star MCQ topic for our exams. So how much is the suggested norms for the health personals? This is just a summary of the whole game. We want in Government of India, we want one nurse for every 5,000 population. You remember the CHOs? We want health workers to be working at 3,000 in hilly tribal forest and 5,000 in the plain areas. We want one trained DAI for every village. We want health assistant for PHC level, that is 20,000 and 30,000, you remember. We also want one pharmacist now for 10,000 population. We want that. These are something new, important that you should remember. Lab technician should be there for every 10,000 population. ASHA worker for every 1,000 population. I am tired of answering this on social media. Please note one ASHA for 1,000. It's not two ASHA for 1,000. The suggested norms that we have in our country is currently one ASHA for 1,000. Also, one doctor should be for how much population? Please note that one doctor we need for 1,000 population. That is the WHO norms. That is the WHO suggested norms for the doctor population ratio. Currently, many states are having more than 1,000 and some are having even less than 1,000. So this is the suggested norms for health personals. And with that, thank you so much for watching and visualizing the healthcare system that we have in our beautiful country, India.